Welcome friends back to my series of lectures on acid-base homeostasis. In the lectures so far, we have discussed about the clinical presentations of acid-base disorders, then we discussed about the classification of acid-base disorders, and we've gone down and talked about the various compensatory mechanisms. In the previous lecture, I discussed about the various buffer systems in the body. I discussed how bicarbonate system as an open system is a very good buffer system, and as a closed system it's not a very good buffer system. We discussed how proteins exert its buffering potentials in the blood, and then we'd gone on to discuss about how hemoglobin as a molecule helps in buffering the blood pH. We discussed concepts of Bohr's effects, Haldane's effects, isohydric and chloride shifts, and how it works beautifully in transporting carbon dioxide from the peripheral tissue to the lungs for excretion, and how oxygen is transferred from the lungs to the peripheral tissue for metabolism. In case you have not gone through that, I request you to go to my previous videos. Having armed with ourselves with the knowledge of how the blood buffer systems work, in the present lecture, we'll discuss about the various compensatory mechanisms, how the respiratory system compensates in regulating the acid-base homeostasis, and how the kidney participates and plays its role in regulating acid-base homeostasis. Now, the respiratory system works through chemoreceptors. Chemoreceptors are those which are sensitive to changes in pH. Now, we have two chemoreceptors in the body, we call the peripheral and the central. The peripheral chemoreceptors are present in the carotids, and these chemoreceptors are very sensitive to the blood pH. The central chemoreceptors are present along the medulla, and they are sensitive to the change in the pH of the CSF. The peripheral chemoreceptors in the carotid bodies sensitive to the pH of the blood. The central chemoreceptors in the medulla sensitive to the change in the pH of the CSF. And remember that there is a physiological blood-brain barrier, and the changes in the blood pH and the changes in the CSF pH do not occur simultaneously. There's a slight lag in this. So, how do the respiratory mechanisms work? Whenever there is a change in the blood pH, the carotid chemoreceptors which are sensitive to the blood pH get activated, they fire, they stimulate the respiratory centers to go into hyperventilation. When you are hyperventilating, you are wiping out the carbon dioxide in the blood. Carbon dioxide equal to carbonic acid equal to acid. So, when you are hyperventilating, you are losing acids in the blood. If you remember the example of the first child who had come to the ICU with hyperventilation and a fruity odor, this is where the respiratory compensation is playing inside. He is hyperventilating to get rid of acids so that it could increase the pH, and the fruity odor is actually ketone bodies which are coming in the blood, and that is an attempt of the body to excrete volatile acids into the blood. Now, this is the first level, this is partial compensation. Now, remember that the blood pH and the CSF pH take a time to equilibrate. So, initial changes in the blood pH induces only the peripheral chemoreceptors to fire, and this is partial compensation. If the acidosis is long standing, then gradually the CSF, the pH also decreases. The pH of the CSF also decreases. Now, this induces the central chemoreceptors to fire off. Now, you are having both compensation from the peripheral chemoreceptors as well as a drive from the central chemoreceptors to hyperventilate and get rid of the carbon dioxide with an attempt to increase the pH. At this stage, we are reaching maximum respiratory compensation. So, the only mechanism of respiratory compensation is hyperventilation when there is acidosis and hypoventilation when there is alkalosis. Now, what is the clinical implication of this information? Usually, when a patient presents with acidosis, we are very aggressive to treat the patient. Now, what happens is, if the acidosis is short standing, this aggressive treatment is very good. If the acidosis is long standing, then when we are doing the treatment, we are changing the blood pH. The moment the blood pH becomes normal, the stimulus from the peripheral chemoreceptors stop. But remember that the pH of the CSF is still low. So, even after the treatment of acidosis, the patient will still be hyperventilating because here the central chemoreceptors are firing. So the practical implication of this is whenever you're treating long-standing acidosis, it is better to undertreat and hope that by the time the CSF pH increases to normal, that bit of hyperventilation which is occurring through the central chemoreceptors will offshoot and undercorrect the treatment which you have undercorrected, so that you don't push the patient to alkalosis. Now let's come to the renal compensation. Kidney is also a very important organ in the body and has a very integral role in regulating the blood pH. So what are the various mechanisms by which the kidney regulates the blood pH? Well, there is a sodium hydrogen and antipode mechanism present in the distal convoluted tubules. There is reclaiming of bicarbonates which occurs in the proximal convoluted tubules. There is production of ammonia by the renal tubules, and there is excretion of volatile acids by the kidney. Now, if you remember renal tubular acidosis, we said renal tubular acidosis has elements of errors in both the proximal and the distal convoluted tubules. So what are these tubules doing and how do these mechanisms help in regulate the acid-base homeostasis? This is what we'll be discussing right now. The first one is the production of sodium, is the sodium hydrogen anti-transport mechanism. Now, when in the normal process of the body, after ultrafiltration, a lot of sodium ions have been lost. The body needs to reclaim these sodium ions for homeostasis. At the same time, there are a lot of acids which are present in the body which the body needs to excrete. Now, here is a set of positively charged ions which you require and a set of positively charged ions which you need to excrete. And what better place to or mechanism to regulate acid-base homeostasis than clubbing up both these requirements into one transport. In the distal convoluted tubule, as the sodium is being reabsorbed, the hydrogen ions are being secreted out in this anti-transport mechanism. So you get the sodium in, that's what you want. You want to push out the hydrogen ions, that's also occurring, and by this simple process, body is getting advantages of getting the sodium and losing the hydrogen ions. This is a beautiful system of molecular intelligence. The issue over here is potassium ions. Whenever there is excess of potassium ions, these potassium ions compete with hydrogen ions for the same transport mechanism for excretion. The potassium ion competes with the hydrogen ions for excretion. So if there is hyperkalemia, if there is increase in potassium, these will get preferentially excreted out with the retention of hydrogen ions, and that leads to acidosis. So if you have hyperkalemia, you end up with acidosis. The next is reclaiming of bicarbonates. Reclaiming of bicarbonates occurs in the proximal convoluted tubule. Now the word reclaim is a concept that the bicarbonates have already been lost and the body is now taking claims whether I need the bicarbonate or I don't need the bicarbonate. If there is acidosis, the body requires alkali, in which case it will reclaim this bicarbonate. If the pH is alright, this bicarbonate is excess, it needs to go off. So there's an elaborate mechanism where the body can reclaim the bicarbonates. Now how does this equation occur? In the ultrafiltrate, you have sodium, you have hydrogen ions. The sodium gets absorbed with an anti-transport mechanism where the hydrogen ions get pushed out. This hydrogen ion binds with the bicarbonates to form carbonic acid. Carbonic acid splits further into H2O and CO2. Now where is this occurring? This is occurring in the renal tubules. Carbon dioxide, being a gas, can easily permeate and enter into the tubular cells, that is the tubules of the proximal convoluted, the cells of the proximal convoluted tubule. In the proximal convoluted tubule, there is the carbonic anhydrase enzyme. This carbonic anhydrase enzyme once again binds carbon dioxide to water to form carbonic acid. The carbonic acid dissociates the hydrogen ions and bicarbonates. This bicarbonate gets reabsorbed. The hydrogen ion present secreted. This hydrogen ion which is secreted is an anti-transport mechanism for another sodium ions to be absorbed. So effectively, you have two sodium ions getting absorbed, you have one bicarbonate ion which is getting absorbed, and you have two hydrogen ions which are being secreted. This is how reclaiming of bicarbonates occur. Production of ammonia. Now glutamine is an amino acid which has got two amino groups. There is an enzyme glutaminase which splits out the ammonia to form glutamate. Now this is heavy biochemistry. The ammonia produced binds to the hydrogen ions to form ammonium ions. Now it is important to know that this is a gas, this can easily come inside, but once the ammonia combines with the hydrogen ion, that forms an ammonium salt. Ammonium salts cannot come back to the system. So this is occurring in the renal tubule, and when that ammonium salt is produced, this salt cannot be reabsorbed. So that way we are forcing this hydrogen ion to get excreted and not come back to the system. So if there is excess acidosis and all your mechanisms are getting saturated, you can produce ammonia, trap the excess hydrogen ions and get them excreted so that they don't come back to the system. This is the importance of production of ammonia. Now, when you have organic acids, these could get filtered, and since there is no reabsorption mechanism, once filtered, they pass out to the kidney for excretion. This is another way by which kidneys can excrete acids. Now, classically, this is the Rotharas test. We know that the ketone bodies formed get excreted out, and if you do the Rotharas test, you get this violet ring, you know that the ketone bodies are positive. Salicylates also, after detoxification in liver, get excreted out in the urine. So this is another mechanism by which the kidney can get rid of excess acids. Now, a small word on chronic kidney disease, anemia, acidosis. Now, chronic kidney disease patients usually have acidosis, and the cause of acidosis is inability of the kidney to excrete the ions. I said that the various renal compensatory mechanisms, secretion of hydrogen ions or reclaiming of bicarbonates gets a bit defective, and also there is an inability to produce ammonia. I said production of ammonia occurs in the renal tubular cells, and production of ammonia is a mechanism by which it can trap excess hydrogen ions as ammonium salts and prevent them from being reabsorbed. When both these mechanisms fail, the acids produced in the body do not get filtered out, and that leads to a bit of acidosis. We also know that the kidney is the center for production of erythropoietin, and erythropoietin is required for production of hemoglobin. So if there is decrease of erythropoietin and there is decreased renal mass, as in chronic kidney disease, anemia results. Now, a chronic kidney disease patient is suffering from acidosis, is suffering from anemia. The body has loaded two things against the human system. But how does molecular intelligence come into play? How have we withstood them? If you actually see a chronic kidney disease patient, they may be having a hemoglobin of 5, but they are not overtly dyspneic. Why? Now, this works because of the oxygen dissociation curve. There's excess of acids. The excess of acids induce the formation of salt bridges. When salt bridges are being formed, there is a tendency for the hemoglobin to lose oxygen. So, peripheral tissues, the hemoglobin loses oxygen earlier. So, the peripheral tissues do not become hypoxic even in the backdrop of severe anemia, and that is because of the baseline acidosis which exists in chronic kidney disease. So, you have anemia on one end, you have acidosis on one end. Use the acidosis beneficially for you to release the oxygen to the peripheral tissues so that the peripheral tissues do not become hypoxic. In the next lecture, we will be discussing about the arterial blood gas report, how to collect samples, what are the pre-analytical variables that occur, what is the difference between VBG and ABG, and then I will give you a plan of interpreting the ABG report. In case you have any queries, comments, suggestions, constructive criticisms are definitely welcome. Please contact me at my email IDs. In case you want me to make videos on any topics, you could also request to that on my email. As and when possible, I will definitely oblige and make those videos. Thank you.